Il dottor
Giorgio Chiogna, PhD, gives a paper by the title Otognatic Syndrome.
Buongiorno.
Good morning. Thanks to the Italian Gnathology Association and its president, Paolo Lodo, PhD, to Eugenio Tanteri, PhD, and to all our group in Turin for having invited me at this conference and having given me the opportunity to speak about the Otognatic Syndrome. The Otognatic Syndrome cannot be limited to a simple internal disorder of the temporomandibular joint, as represented by this slide that outlines it, as a diagnostic imaging does in the different phases of alteration of the condyle disc ratio to the condyle arthritis. The term Otognatic syndrome appears for the first time in a Myraf article in 1964, where he describes interesting otologic symptoms such as tinnitus and dizziness in patients affected by temporomandibular disorder, TMJ, disorders and related pain conditions. Therefore, tinnitus and dizziness can be part of the ailments connected to the temporomandibular joint disorders. Since ancient times, epidemiological studies found the presence of otologic symptoms in people presenting TMJ disorders.
Sintomi otologici all'interno dei disordini interni dell'articolazione temporomandibolare.
Even a large production of scientific literature highlighted the presence of otologic ailments when people suffered from TMJ disorders.
Temporomandibolare.
What is tinnitus in particular? It's a personal perception of sound within the human ear, ringing of the ears, when the external sound is present, as we can see in the definition reported by Wikipedia. Therefore, it is an involuntary sound production of the ear of a person suffering from this disease that can produce not only buzz. We need to make a differential diagnosis between the multiple causes of tinnitus, since as you can see in these two slides, they look more like a phone book than a simple listing of symptoms, because we need to find an indication that could help us, gnathologists, to treat this problem through a dental occlusal approach. In fact, we need an ETN specialist to give us the indication to treat the problem, working on the dental occlusion of the patient. Basically, the ETN specialist brings his case to our attention when he rules out the possibility that it is a neurosensory tinnitus, because we can treat only somatosensory tinnitus. In fact, this kind of tinnitus has a muscle origin, and later on we'll see how the functional disorders incidental to internal TMJ disorders could give this symptom. The other family of tinnitus, the neurosensory, is due to induced neurological damages or to a damage of the cochlear hair cells. The patient of these two slides came to me because she presented symptoms strictly connected to the TMJ, such as problems in opening the mouth and deviation of the jaw sideways. She also presented otologic ailments such as tinnitus and dizziness. Expert eyes will immediately notice that this lady has a facial winking mimic problem as a consequence of damage to the seventh cranial nerve. Undeniable by the panorex or DPR, the patient has occlusive problems, a poor occlusion presenting an inversion of the occlusal plane that could give rise to joint symptoms. But as well, we will see later on, it could also cause somatosensory tinnitus. However, her otologic symptoms had a different nature. In fact, this lady declared to feel paresthesia at the lower left lip, which is not one of the natural symptoms of a TMJ disorder, temporomandibular joint disorder. This made me think of the possible presence of other problems, such as the compression of the third branch of the trigeminal nerve. For this reason, thanks to an MRI of the head, we could find a mass that could be defined as a neuroma of the acoustic nerve that, besides the seventh cranial nerve, compressed also the fifth one.
Un piccolo ripasso dell'anatomia.
Let's now review human anatomy very quickly. This is the ear. Very important sensory organ. The ear is made of a structure where the acoustic waves arrive. The eardrum and system of mechanical transducers, the chain of tiny bones that through the stapes transfers the acoustic waves to the oval window of the endolymph of the cochlear. The eustachian tube opening keeps the pressure present between the two walls of the eardrum. The external one subject to atmospheric pressure and the internal one facing the middle ear, where the atmospheric pressure arrives when the tube opens low. In fact, the eustachian tube closes between swallowing, and this temporary closing action keeps the ground noise caused by the air free to enter the eardrum camera out. The swallowing function avoids the creation of a stable negative pressure inside the eardrum cavity. This is why, thanks to the opening-closing function of the eustachian tube, we can achieve a functional equilibrium. The eustachian tube, closing and reopening, keeps the air from entering freely, creating a direct stimulation on the ossicular chain and therefore preventing the atmospheric wind in the middle ear from producing an annoying ground noise. In short, the perceptible waves hit the eardrum passing through the external auditory meatus and make the eardrum vibrate. At the same time, the eardrum transmits this vibration to the ossicular chain and then to the cochlear. The hair cells inside the cochlea depolarize according to the frequency received, get in the position intended for such frequency inside the cochlea and convert the sound signal into an electrical signal detectable by the brain. This slide also shows the tensor tympani muscle that we will analyze later, besides the eustachian tube.
Allora, la staffa.
This slide shows the stapes on the oval window of the cochlea, in which it transfers the mechanical stress to the endolymph up to the apex, the so-called helicotrema, stimulating the hair cells that vibrate in the tectorial membrane and depolarize, producing a neurological signal.
Adesi alla membrana tettoria e quindi producono una depolarizzazione di queste cellule e quindi un segnale neurologico. Contiguo al sistema.
By the cochlea, we can find the endolymph of the semicircular channels, a critically important system. The semicircular channels are designated to the proprioception, the orientation of the head in space, that thanks to the otolith system give the perception of gravity. Otoliths could move due to the excess of endolymphatic pressure and therefore produce the motor instability typical of canalithiasis.
Questa è la visione di
The
dettaglio.
slide shows in detail the insertion of the handle of the hammer, of the chain of ossicles of the tensor tympani muscle I talked about in slide number 17. This muscle is innervated by the medial pterygoid nerve, a part of the third branch of the trigeminal nerve. Therefore, when the medial pterygoid nerve contracts, the tensor tympani can contract as well.
Mediale si contrae anche il tensor
The
timpani.
medial pterygoid nerve innervates also the tensor veli muscle, which moves the soft palate towards the rhinopharynx. The functional integration that the trigeminal nerve creates is understandable because the chewing function happens before the swallowing that can happen only after having stabilized the occlusion, which allows the tongue thrust that pushes the hyoid bone up, contracting the tensor veli and positioning the soft palate in order to close the airways, open the eustachian tube, contracting the pericephaline muscle in order to transfer the atmospheric pressure in the eardrum camera, pushing the eardrum towards the external auditory tract that the tensor tympani contraction contrasts at the same time.
Come si vede in questa
As we can see in this slide, The tensor tympani and the tensor veli combine in a tendinous raphe that connects them to the malleus, or hammer, on the eardrum. This slide has been created to analyze the bone structures of the cranial region where the muscles we are talking about origin. We can see, on the right, the joint prominence of the temporal bone where the condyle is located, moving counterclockwise the petrotympanic suture. Next to the sphenoid, the scaphoid fossa on which the tensor veli origins. The wool thread passes through the round hole in its middle meningeal artery. The metal wire exciting from the bone canal of the eustachian tube continuing into the cartilaginous part that, black on top and red on the bottom, is surrounded by external and internal peristaphyline muscles that open the tube during the swallowing functions. The tensor tympani muscle origins from the bone tunnel of the eustachian tube and the external part of the tube cartilage that here on the skull cannot be seen anymore.
L'anulus, l'uncus del
This slide shows another view of the same area, where you can see the pterygoid hemilus process, where the medial pterygoid and tensor veli origin. The tensor tympani origins from the sphenoid that in the picture is visible beyond the pterygoid processes.
Nel processo, come dire, dello sfenoide e, come dire, si inserisce all'interno dell'orecchio, della cassa timpanica. Quindi,
Therefore, the tensor tympani muscle can be considered as a strange chewing muscle, as defined in this 2007 article by Ramirez, since if we contract the medial pterygoid muscle, we contract also the tensor tympani.
questo è
In this slide, we can see the palate and in the upper maxillary tuberosity that ends in the soft palate, the origin tendon of the tensor veli. The plaster dental impression we developed was taken from a 60-year-old lady suffering from obstructive apnea.
rafe tendineo di inserzione del tensor veli. Allora, ritorniamo all'acufene.
But let's now return to the main subject of my participation at this Congress, tinnitus. In the famous Topographic Anatomy written by Testud, a book considered binding, in its Italian version dated 1933, at page 326 writes, the tensor tympani muscle can be subjected to such a contracting retraction that the eardrum membrane sinks in it deeply, causing deafness and tinnitus. The advised surgical intervention is the tenotomy of the tensor tympani proposed by Weber and Leal in 1868.
1868 dal dottor Weber e Leal. Questa è la
This is
pubblicazione.
the British Medical Journal issue, 1875, that speaks about this kind of surgery. This surgery is still up to date, and it has been reanalyzed in a 2013 article published by Otology and Neuro-Otology by Hidaka and colleagues, who suggested this surgery as a surgery solution for serious tinnitus.
Quindi questo
This
tensor
means
timpani
that we should reconsider the different functions of the tensor tympani muscle, which, in small contractions, such as swallowing, it tends to reduce the perception of sounds, making the eardrum conical and less efficient. During slight hypertone, instead, it stiffens the ossicular chain and therefore tends to increase the perception of sounds and give a hypercosis feeling. During serious hypertone, on the other hand, the stapes sinks deeply in the cochlear oval window, creating tinnitus and deafness, and can move the otoliths in the semicircular canals, causing canalolithiasis with dizziness.
caso A.
With this slide, I will start presenting the case subject of my speech. The main problems of patient are cervicalgia, lower central incisors instability, tinnitus, motor instability.
Questa
This is
è
the
la
patient's
persona.
mouth in her maximum intercuspidation on the frontal plane. The problem for which she went to the dentist, lower central incisors mobility. The panorex shows clearly the loss of bone support of the lower central incisors. In this case, We're treating the dental paradigm in the sense that Theodore Kohn gives it to this term. The patient went to the dentist for her dental problems, but she had other collateral ailments. The dentist was called in to solve her dental problems, but solving them, he solved also the very serious collateral problems that at the time I didn't think I could treat, because my therapy aimed to stop the loss of the lower incisors. As you can see, the bone support is at minimum, free from periodontal pockets, typical of occlusal trauma damage. This is the cephalometric tracing. On the left-hand side, on the side of the skull, we transfer the model of the lower arches mounted on the articulator thanks to a graphic system, and the extent of the deep bite in a second-class ratio is clear, according to Engel. Here, we can see the dental treatment. The alignment through an Australian wire 0,016, and in the first alignment phases already, we can see that the jaw moved forward alone, without any kind of elastic stress.
Come di sollecitazioni meccaniche. Poi è stato chiuso il caso col MIU.
Then we closed the case using the MIU technique, multi-loop edgewise arch wire. And 12 months later, this is how the case appears. The incisors are stable. This slide shows how the occlusion ratio now is first class. Here, on the side of the skull and the relevant cephalometric tracing, we can see that the anterior repositioning obtained lasted unchanged for 6 years, and the patient never suffered from tinnitus or any of the problems she had before the treatment anymore.
Caso B. Problema principale
Case
è la
B
acufene.
was sent to us by the ETN specialist because she suffered from tinnitus. During the clinical exam, the patient presents a painless hypertone of the retromaxillary lateral space, where palpation finds medial pterygoid tensor veli and tensor tympani, but cannot find the lateral pterygoid.
Tensor timpani e lo pterigodeo mediale. E non si palpa lo pterigodeo laterale. La paziente ha
The
un
patient
problema
has
odontoiatrico,
dental
ma non
problems,
viene per un problema
but she doesn't come to us
odontoiatrico.
to cure them. In fact, to treat her problems, we need authorization, and it comes from the ETN specialist who sends us the patient after having carried out his instrumental clinical exam that helped him make a diagnosis for somatosensory tinnitus, since only an ETN can record the sounds produced by the cochlea, the otoacoustic emissions, and evaluate the elasticity of the ossicular chain through a multi-frequency impedation metric exam, and the variation in the dental clamp or occlusion. Therefore, tinnitus comes a personal symptom and not a recordable one.
Acufene è un sintomo soggettivo non rilevabile oggettivamente, ma può essere rilevato dall'odorino. Il serramento dentale aumenta la frequenza e varia le caratteristiche dell'acufene. Questa è una situazione che
This is a case of dental wear. Once worn the box checker, it's clear that during the night the patient suffers from bruxism of the back molars, where the occlusal plane reverts.
è stata anche fatta
We
un
also
esame.
performed an exam with the Braxoff, which has been able to record the contractions of the masseter during her sleep and the episodes of sleep bruxism, identified as maximal contraction, preceded by the increase of the heart rate connected to sleep apnea, according to the studies carried on by Jill Lavigne.
Allora, il
The
piano di
treatment plan
trattamento è stato
envisaged the rearrangement of the patient's jaw in therapeutic position, according to the technique proposed by Alan Landry, which examines the variation in tone and possible palpation pain of the lateromaxillary area I just described.
ho descritto prima, che è la tuberosità del retro morale. E quindi ho variato la
Changing the
dimensione
position
verticale.
with a splint test carried on with the help of Rudolf Slavicek's cephalometry, the splint test was then replaced by a protrusive bite with a retrusive stop, very important in this particular second-class case because in order to avoid the exacerbation of the jaw back motion, we needed to raise the vertical height very much. I put the bite on and verified the lateral skull line with a new cephalometric tracing. This is the layout before the articular rise at low vertical dimension. This is the tracing carried out after the protrusive articular rise, in which I normalized the vertical dimension. The inversion of the occlusal plane at 37-47 level made me decide to modify not only the vertical and antero-posterior jaw position, but also its occlusal plane orientation, stopping by teeth number 36-46. Once regulated the occlusal plane, the wax model was made in plaster. We made dental masks and then mounted them on the mouth of the patient with the retrusive stop at first premolar level.
In
both cases, tinnitus disappeared. Cases interpretation introduction. The slide shows a scheme of the ontogenesis of the stomatognatic system. Meckel cartilage, first branchial arch, where jaw, condyle, malleus or hammer, and anvil origin. Reichert cartilage, second branchial arch, where stapes, styloid process, and lesser horn or cornu of the hyoid bone origin. Third branchial arch, hyoid bone and pharynx structure. This slide shows the structural excess in an adult made of the discomalleolar ligament or Pintos ligament that connects the back part of the capsule to the handle of the malleus hammer. Here, in the roto translation, we can see the structural connection existing between Pintos ligament and the ossicular chain. And in the final part of the video, we can see how the cranial cut of the anatomic model shows the proximity between the condyle disc apparatus and the ossicular chain. The development of the skull from the evolutionistic point of view brings mouth to move back and the skull to erect.
Del mascellare, l'innalzamento del cranio.
At the same time, both arches of man shut. And in the ontogenesis, from the swallowing activity typical of newborns, we pass to the chewing cycle with the formation of the jaw branches and the TMJ joint eminence angle. With the new chewing and swallowing actions, the antero-posterior movement of the condyle must turn into rototranslation. This is a scheme of Professor Joseph Sborny, where the temporomandibular ligament is described as the anatomic constraint that allows only a clockwise rototranslation. What is our goal, as defined by Professor Sadao Sato? Reduce the muscle activity of the stomatognatic system, placing the condyle in its physiological position inside the fossa and harmonizing the occlusion in order to reduce muscles' hyperactivity. In this case, we also reduce the hyperactivity of the tensor tympani muscle. We carried out a Braxoff exam before and after the bite. In patient B, we go from 6 hours to sleep with almost 2 episodes of night bruxism per hour and 40 contractions of the masseter, to 10 hours of sleep and only about 1 episode of night bruxism per hour, with a large increase in the number of contractions of the masseter, which for now have tipping characteristics. In patient A, who had a deeper bite, as Professor Sadao Sato and his group made clear, it generates a counterclockwise rototranslation. I carried out a condylography of the patient using double stylus gamma software that evaluated the extent of the clockwise and counterclockwise orientation of the condylar rotation of the TMJ lower articular camera.
La paziente ha una rototraslazione con gamma negativo.
We can see that at the beginning of the cure, the rotation was inverted with negative gammas.
Movimento della mandibola invertito, quindi con gamma negativo. Alla
And that
fine,
at the end of the therapy, gammas regularize a turning positive that is clockwise.
la
Patient B,
paziente
the
B
condylography during the analysis of the terminal hinge rotation movement presented a posterior contact by number 47. Let's now see how it modifies in bruxism.
la faccetta che tipo di movimento abnorme genera a livello del manicotto condilo discale. Quindi
In case
vediamo
B, we can also see that the beginning of the therapy, gamma was excessive and stabilized only after the treatment.
accentuato, c'è un gamma positivo ma eccessivo. Quando invece è stato
As well as
ripristinato un
repositioning the Brax checker on the bite during the night, the muscle contraction activity has increased. But now, from negative gamma, counterclockwise rotation, bruxism, we passed to simple tipping.
che però è un tipping più che un bruxare.
Therefore,
Quindi, l'intervento
our
occlusivo-
occlusive interventions were able to solve the acoustic problem influencing the condyle disc rotor translation. They acted on the lower TMJ camera, correcting case B muscle hyperactivity that caused an excessive rotation gamma angle, and that, more specifically, caused a counterclockwise rotation gamma angle, overloading Pinto's ligament and, with it, the ossicular chain. In both cases, clockwise or counterclockwise rotation, tinnitus had been caused by a dental occlusion that had altered the system of the transmission of sounds. That's why tinnitus has been resolved working on the occlusion directly on Pinto's ligament, regulating the gammas, while in case B was resolved reducing muscle hyperactivity on the medial pterygoid and the muscle connected to it, and especially the tensor tympani. I would
Vorrei
like
chiudere
to finish
così.
with this slide. This isn't a pipe, and this isn't a mouth.
Un ringraziamento al
I would like to
professor
thank
Claudio.
Professor Klaus Abreu for having brought to Italy the Viennese school, and I would also like to thank Professor Rudolf Slavicek and Professor Sadao Sato for having opened the wide horizon of therapy to gnathology.